Okay, so welcome back. Hopefully you've had an opportunity to interact with the first half of the online presentation. So that was thinking about pharmacokinetics and pharmacodynamics, and really why as physiotherapists we need to be interested in how drugs act on our body. So we're often in conversations with our patients and with our colleagues around medications used to manage pain. So it's an area that's common to all specialities, and I think helps us understand or put into practice our understanding around pharmacology. So to do that, we just need to briefly reflect on some of your learning from the pain neurophysiology seminar that you had a couple of weeks ago. So there really we reflected on the physiological processes that occur when we have a pain experience. So we talked about nociceptive transmission, so that's transmission from the local peripheral areas of damage, tissue damage, and that we get stimulation of a range of receptors, so that might be nociceptors, mechanoreceptors, that would then transmit a message via our sensory nerves back to our spinal cord, and that different types of receptors will transmit that information using different types of nerve fibres, and that those different nerve fibres will transmit at slightly different speeds. And then once it arrives at the spinal cord, we're going to get some action at spinal cord level. So, for example, the information might trigger a flexor withdrawal action, but we'll also get transmission of that information up to the brain, where the incoming information is going to go via the thalamus to the somatic sensory cortex and a range of other areas in the brain, and the brain is then going to respond from a behavioural perspective in a range of ways depending on the perceived threat level or danger level of that incoming sensory information. And the responses and that assessment of danger level are based on a range of factors. So the activity that the person's doing, the environment in which they're doing it in, have they seen someone in the same sort of situation before? Have they been in the same situation before? So a whole range of previous experiences, learnt behaviours, so we're drawing in all the association areas and memory. And then we get a motor output, behavioural output. So we will change our motor behaviour depending on the threat value of the pain experienced. And we discussed how the central nervous system can modulate pain via descending inhibition, as well as we also went on to discuss processes where once tissue damage has healed, there may be still the presence of pain and someone still having a pain experience. So we discussed peripheral and central sensitization and some of the processes that occur whereby someone would still be experiencing pain even though tissue damage is no longer the stimuli for that pain. So if we think about an acute situation, so this is just an example of someone who has tripped and injured his ankle during an important football match and presented an accident emergency. So we've got signs of inflammation going on here. We've got swelling, redness and heat coming from the ankle. So that would indicate to us as healthcare professionals that there's likely tissue damage. So we will have responses from your mechanoreceptors, your nociceptors, and those pathways via the sensory nerve, spinal cord, central nervous system will respond to the injury. Now, there's two things in here that might make us think about his pain experience. in relation to this level of tissue damage. So he's playing an important or vital football match. So we know that that's likely to lead to some level of descending inhibition or modulation of his pain at the very early stage. So when he had his very initial injury, he may not have had as intense pain experience as perhaps we'd expect, because of the importance of the game. It might be more important from his nervous system's point of view to continue playing. However, at this point, whilst he's in accident and emergency, there's visual signs of the tissue damage, and it's going to be clear to him as an individual that he's not going to be playing football for some time. So that might lead to these high levels of distress and anxiety, and that's going to lead to a more intense pain experience. So this is just to recap some of the processes that happen during tissue damage and the inflammation process, the sorts of things we'd see happening, so pain, heat, swelling, what's happening at a tissue level and at a chemical level. So I'll just give you a moment or two to read through there. Okay, so when we're thinking about analgesia, we need to be thinking about where in the system that might be acting. So some of the medications we use from an analgesia perspective will act directly on our central nervous system, so your morphine-based medications, and they may act at different points during the nervous system, in the nervous system. So at synaptic level, they might bind onto a postsynaptic receptor. They might excite or inhibit the receptor neuron, so we might still get the same amount of neurotransmitter released, but actually the neuron receiving that neurotransmitter may either respond to it more or less, depending on how the drug has influenced that neuron. The drugs may in fact change how the neurotransmitter is reabsorbed, and that will alter neural transmission. And we might find that the neurotransmitter, how that signal is transmitted across the synaptic cleft in the first place, is also altered. So there's a range of ways that medications, drugs can influence the nerve transmission itself. So this is something called the analgesic ladder, and it's developed by the World Health Organization, initially used very much for cancer pain management, but has been widely adopted in pain management services. So it's a hierarchical model, and it's about managing, optimizing pain management, using a range of different classes of medications. So we've got step one, where we'd be using non-opioidal medications such as aspirin, paracetamol, or non-steroidal anti-inflammatories, plus a range of adjuncts, non-pharmacological adjuncts that would be there to manage the pain. So you could be thinking of this at that acute initial injury stage, so that's where things like heat, ice, TENS might be useful, in conjunction with your aspirin, your paracetamol, and or your non-steroidals. If the pain is, we would then be wanting to think about, is the pain controlled? If it is, this would be the step that we'd stay at. If not, you might be thinking about moving up a step onto the weaker opioids. And we're thinking about mild to moderate pain. So examples might be codeine, in conjunction with some of the non-opioidals. So your aspirin, your paracetamol, etc. And then you would, along with any appropriate adjuncts as well. And then the third step would be introducing your stronger opiates. So this might be for more persistent, moderate to severe pain. So morphine would be an example, or Oromorph. You might continue with your non-opiates as well, so the step 1 drugs, and you might continue with your adjuncts as well. So it's moving through that ladder. Now what I'd like you to do is just pause the presentation for a moment and just jot down your thoughts on that. So do you think that that this is an appropriate way to manage all pain? What do you think the strengths and the weaknesses are for something like this analgesic ladder? Okay, so I'm going to finish the screencast here, and what I'd like you to do is bring those thoughts with you to the online seminar, which will be later on this week. Okay, thanks very much.